77 male patient underwent left hemicolectomy after presenting to A&E 2 weeks ago with a bowel obstruction. He has a stoma in situ, bilateral JJ stent. Biopsy confirmed the diagnosis of rectus sigmoid cancer. Please perform an abdominal examination and present your findings. The main comments in the stoma examination is to find out the site and the size of the stoma, and is it flat or sprouted, and is it 1 lumen or 2 lumens, and is it viable or not? Is there any signs of infarction or infection? Is it edematous? Is it prolapsing? Is it associated with hernia? Each one of those does have significance in establishing your diagnosis of the stoma. I would classify this examination into 3 things. Number 1, the anatomy. Number 2, the type of the stoma. And number 3, the possible complication exclusion. Regarding the site of the stoma, it's either one of 2 things. If it is on the right iliac fossa, it's most probably to be an ileostomy or a urostomy. On the other side, if it is in the left iliac fossa, it's most probably a colostomy. The next question is how to differentiate between ileostomy and colostomy. The question here is about the site. Ileostomy is always in the right iliac fossa, whereas colostomy is always in the left iliac fossa. Ileostomy in one side is always spouted, which means it's slightly elevated from the skin side. Colostomy on the other side is always flat, which means it's not raised from the skin side. So, ileostomy is on the right iliac fossa and spouted, and colostomy is on the left iliac fossa and flat. Next question is about the number of the lumens. If we do have 1 lumen, it's an end stoma. And if we have 2 lumens, it's a loop stoma. So that gives us 4 differentials. Whether it's an end ileostomy, a loop ileostomy 2 lumens, an end colostomy 1 lumen, and a loop colostomy and 2 lumens. Each one of them does have different indication from the other one. End ileostomy, for example, can be used in emergency subtotal or segmental colectomy, and in conditions like ulcerative colitis and loop large bowel obstruction. Basically, in any condition that will require removal of the colon. Loop ileostomy is better for defunctioning, for whatever the reason is. It could be for saving an anastomosis, or for emergency colectomy, or abdominal bone resection, or maybe an obstruction like colonic or peritoneal cancer. Endocolostomy is helpful after removing large part of the left colon. It could be after Hartmann procedure, emergency colonic perforation, anastomotic leak, or elective cancer fistula who had not tolerated anastomosis. Finally, loop colostomy is also better for defunctioning, for example in distal anastomosis, obstruction, rectal cancer, or stricture, or functional incontinence fistula. Let's differentiate between different stoma types. This is a stoma on the right iliac fossa, and it has a spouted shape. So as you can see, it's slightly elevated from the skin side. And if you look closer, it does have 2 lumens. One is slightly elevated in the spouted area, and the other one within the flat distal part of the lumen. So, now we have a right iliac fossa stoma, spouted, and it does have 2 lumens, so that make it a loop ileostomy. Another is stoma on the left iliac fossa. If you look closer, it is a flat stoma, it's not spouted, and it has 1 lumen if you look closer. So this is an end colostomy. Let's talk about a few complications. Number 1 is an infarction, which means complete cut of the blood supply from the stoma site, either due to strangulated hernia or ischemia. Number 2 is retraction. This can potentially lead to stoma obstruction. And number 3 is prolapse. And number 4 is stoma hernia. And it will be corrected the same way that we will correct a hernia by a mesh.